A 62-year-old lady presented with a slowly enlarging lump in her left flank. I am showing you contrast-enhanced abdominal CT scans. Describe the findings.
Let's see. Yes. The contrast-enhanced CT scan depicts a massive, predominantly fat attenuation mass in the left side of the abdomen. Numerous abnormal, tortuous vessels course directly within this large mass. The mass itself arises from the left kidney and displaces it anteromedially. Importantly, further smaller fatty lesions are visible within the cortices and parapelvic regions of both kidneys.
I am showing you catheter angiography spot images of the renal arteries. What do they demonstrate?
The angiography spot images demonstrate a large left renal artery that has been displaced inferiorly by the mass. This artery gives rise to numerous abnormal, hypertrophied, and tortuous feeding vessels. The right renal artery and its branches are completely unremarkable with no abnormal vascularity.
I am showing you a post-treatment spot image and an additional CT slice. Describe them. State the diagnosis and explain the tissue composition.
The subsequent spot image demonstrates successful embolisation of the aberrant left renal branches with coils and PVA particles. The extra CT slice confirms small fat-attenuating cortical lesions bilaterally. The diagnosis is multiple renal angiomyolipomas. Pathophysiologically, these are benign neoplastic lesions made up of vascular tissue, smooth muscle, and mature adipose tissue.
What are the key differential diagnoses for a fat-containing renal mass? How do you differentiate them?
Differentials include renal cell carcinoma, retroperitoneal liposarcoma, and adrenal myelolipoma. Renal cell carcinomas can contain macroscopic fat, but typically show calcification and central necrosis when large. Liposarcomas are less vascular and tend to invade the renal parenchyma rather than presenting as an exophytic lesion. Adrenal myelolipoma arises from the adrenal gland itself rather than the kidney and contains no smooth muscle or vascular tissue.
Explain the syndromic associations and the clinical management of renal angiomyolipomas.
Multiple bilateral angiomyolipomas are strongly associated with tuberous sclerosis in 80% of cases. This association warrants careful clinical evaluation, including a brain MRI and echocardiography to screen for subependymal nodules and cardiac rhabdomyomas. The major clinical risk is spontaneous severe retroperitoneal bleeding, which is high for lesions exceeding 4 centimeters or with vascular aneurysms. As a radiologist, I would recommend prophylactic transcatheter arterial embolization as the first-line management for high-risk lesions. Surgical resection or partial nephrectomy may be necessary for fat-poor angiomyolipomas where renal cell carcinoma cannot be excluded.